Sekejap.
Okay, good evening everyone.
Belum.
Belum.
I'll cue you in. Sekejap Okay. In 3, 2, 1.
Okay, good evening everyone. Welcome to our weekly webinar on a Wednesday. Last week we had a psychiatric talk on depression. Today we will talk about psychosis, and we have none other than the renowned Prof. HATIM. Actually, I've met HATIM in another webinar about 2 years ago. Okay, and he was then the head of department, and Prof. HATIM also has a PhD. HATIM, come on in.
Okay. Very good.
What's your PhD on?
Sorry?
What's your PhD on?
My PhD on psychopharmacology.
Oh, I see.
Psychopharmacology, yeah.
Okay. So you did your master's in psychiatry?
Yes, correct. I did my master's in psychiatry. And then after finishing, about a few years after that, I did my PhD in psychopharmacology.
And now you are full-time in
UM, yes.
right?
Yeah, I'm full-time in
and you
UM.
also have a special private practice in UMSC, right?
No, unfortunately, I focus only in UM.
You don't have a private practice in UMSC?
Yeah, no. I do a lot of clinical trials. So,
I see.
so because it takes a lot of time doing the clinical trials. So I work
see.
more with the industry and the pharma company doing the clinical trial. Yeah. So
I'm surprised you don't have private practice in UMSC, because a lot of people find it very lucrative, right?
Yeah. But I'm more into research, so I do more of clinical trials, new drug development. So
that's interesting.
yeah.
Okay, maybe without further ado, you can continue. You can tell us a little bit more on psychosis and some interesting cases.
All right. Thank you very much. A very good evening. Thank you, Dr. Betty, for the kind introduction, and thank you for inviting me here today. It's a great pleasure to be here in this webinar. And I was asked to talk about psychosis. So I'm not sure what is interesting about this psychosis case, but I try to make it interesting.
For us,
because,
all psychosis cases are interesting.
Because Dr. Betty suggests this topic. So it's okay, I said I agree, interesting psychosis case studies. So I'll be presenting on 2 different cases just to highlight on 2 important, I think, illness. So before we start, probably just a background on psychiatry. So there's a lot of stigma, unfortunately, associated with psychiatry, and mainly because of psychosis. And there's a lot of misunderstanding, especially the public. They don't understand about they always thought psychiatry or mental illness is not a disease. Public always thought this is due to charm, penyakit buatan orang, or because of demons, bad spirit, because of jinn and shaitan, that's the common. If a patient presented with psychosis, they always blame the spirits, the natural, the demons and bad spirits. And also people always link psychiatric illness because you are weak-willed, your personality is weak, you are lazy, that's why you develop mental illness. But actually it's not the case. Mental illness is just like other chronic illness. Anybody can get depression, anybody can get schizophrenia, anybody can become psychotic, and it's just another chronic illness. And another misconception is that a lot of people thought that the illness will just go away by himself, recover, just be strong. We are not Wolverine who can self-regenerate and recover. So you need treatment. You need to go to the doctor. So mental illness are also brain disorder. Unlike stroke, which is disorders of lesion, if you do a CT scan, you can see where's the stroke, where's the lesion, or Alzheimer's disease, you can see the brain shrinking. But a mental illness, you can't really see physical disorder in the brain. Yeah? So it's more of disorders of the circuit. And it results from complex genetic risk factors, developmental factors, and environmental factors. So there's no single factors that cause mental illness. It's a multi-factorial kind of thing. Yeah? So it's not one factor that causes mental illness. The good news is that there's a lot of new treatment, available treatment that actually can help improve the patient, or even the patient can go into remission. They can go back to their normal daily function. Yeah? But the key word is that you need to detect early and treat appropriately. Yeah? So early detection, early treatment, patient can go back to society. They can function just like normal people. Eh? So there's a lot of current treatment available, be it for schizophrenia, bipolar, depression, anxiety. There's a lot of new treatment available, new development available for psychiatric illness. Okay, so I go for the first case. So, so this is a 27-year-old male, married. He works as a technician. So brought to the psychiatric clinic in PPM by the wife. So the chief complained because the wife said the patient was threatening his office mate, trying to beat up the office mate, always want to fight with the office mate. So he's working at a construction company for the past 4 years. However, past 1 year, the wife noted that, and also the employer noted that there's deterioration in the patient's work performance. It used to be very good, but slowly they can notice there's some deterioration in work, very slow in doing his job. So 6 months before coming to clinic, started to have some persecutory delusions. He believed that his office mate is trying to frame him, making him lose his job, trying to bad things with him, and he also have delusions of reference. When he read the newspaper, he thinks that the news is about him. And a few months after that, I also have been hearing voices, so especially the voice of his office mate and also voice of his neighbors. They're talking bad about him and ridiculing him. So because of that, start to have poor sleep at night and start not to trust anyone, slowly withdrawn from the society, does not want to mix around, feel life is in danger, and avoiding family members and relatives. So according to wife, he does not abuse drug or alcohol, and there's no previous medical or psychiatric illness. So there's also a reduced amount of speech. Speech is much reduced, always very preoccupied with his own thoughts. And recently started to show threatening behavior, especially towards his colleagues at work, started to want to fight with them, threatening them. So the employer asked the wife to bring the patient to hospital for assessment and for treatment. So basically, this is quite a straightforward case of schizophrenia, which is patient presented with a chronic form of psychosis. Normally, schizophrenia, they always start with a reduction in functioning. So it's a chronic disabling disease. Schizophrenia is a chronic disabling disease, one of the worst psychiatric conditions to have. It affects less than 1% of the population and is found all over the world. Even though the prevalence is relatively low, but actually it counts for 50% of mental health admissions because it's a chronic illness. It's a chronic illness. So this illness causes significant morbidity and mortality. So basically it impairs the patient's perception. Perception is the where patient have abnormal experience, like hearing voices. So we use our 5 senses to detect the stimulus, and then all the sensory stimulus detected by stimulus and sent to the brain, and the brain will perceive. So that's now I'm talking to you. You can hear my voice. Yeah? You can see my face in this online. So your brain is perceiving there's HATIM is talking to me on schizophrenia. So that's normal. But abnormal perception is that there's no stimulus, but your brain still perceives. So that's abnormal perception. So that's hallucination, we call it. So it's one of the psychotic symptoms. Psychotic symptoms, one is hallucinations, which is disorder of perception, which what we call is impairment in reality testing. So that's one symptoms of psychosis, which is a serious symptoms. If you have hallucinations, you start hearing things, you start seeing things that others can't see, and the quality of the perception as if there's a real stimulus present. So it's not an imagination. So the patient actually really hears things, see things, smell things, or taste things. So that's related to our 5 sensory organs. So that's hallucination. So it's a sign of psychosis. And illness that impairs the thinking, which is what we call a delusions, fixed false belief. Patients suddenly will develop this abnormal belief, which is, there's no evidence to it, but patients suddenly develop that belief. So it's what we call a delusions. And in this case, patient believe that the office mate is trying to harm him, and it's probably related to the hallucination as well. He's hearing voices. The office mate talk bad about him, and of course he feels that they have bad intention. So this is the second symptoms of psychosis, which is delusion, disorder of thought content.
Can
So of
I
course,
ask you, sorry,
yeah,
can I stop
yeah,
in here? Why are most thoughts ill-intentioned thoughts? Don't they feel like oh, people are being very nice to me? Is there a possibility?
yeah, okay. There's depends on the delusion. There's also grandiose delusion that they feel that there's inflated self-esteem.
Oh,
I
no,
feel
no. Like,
that
for
I'm
example, they
better
feel like
than
people love
most
them,
people,
people buy them things. Do they feel that?
Sorry, it was cut
Oh,
cut
sorry.
off.
Do they feel like are there times when the delusion is a good one, like they're so loved that people love them so much, people want to send them things? Are there
That
delusions like that?
that is also possible, but
Possible.
most of the time the delusions are most of the time is bad, is something that's causing distress.
Okay.
Same like hallucination, you always hear things that is bad, or you smell things that are not a flower smell but a stinky smell, so
Oh,
something
yeah.
that is because this is part of the illness, the brain, how the brain process it.
Okay.
Okay. And because of these psychotic symptoms, of course, they affect the emotions. They can become depressed, they become afraid, they become worried. And again, because of the psychotic symptoms, they don't want to interact. They become paranoid, and this will definitely affect their function. They don't want to mix with people. They don't want to mix with their family. And they don't want to go to work. They cannot focus because their mind is preoccupied with all these psychotic symptoms. So this is very chronic and cause a lot of impairment to the patient. So unfortunately, develop among the young adult, around 20 years old. So if you are already past 45 years old, you are safe. Most likely won't get schizophrenia. So for me and Dr. Betty, we are safe. We won't get schizophrenia.
I'm so happy for that. So comforting.
Okay, the risk is same for male and female. Unlike depression, it's higher risk for female, but for male, for schizophrenia, the risk is the same, male and female. So what are the etiology, the cause? It's mainly neurobiology. So there's a lot of hypotheses. One is what we call dopamine hypothesis. I'll elaborate this dopamine hypothesis in the next slide. There's also brain abnormalities associated with schizophrenia. There's a shrinking of the brain to a certain extent. There's because of the ventricular enlargement, or that's what we call hypofrontality. There's low activity of the frontal lobe, which gives rise to negative symptoms. There's also genetic influence based on genetic studies, twin studies, family studies. If you have a monozygotic twin having schizophrenia, then the twin will have 50% chance of getting schizophrenia. If your parents have schizophrenia, then you have about 10 to 15% chance of getting schizophrenia. So there's some genetic factor as well, but there's no single cause for schizophrenia. It's a multifactorial. So based on the dopamine hypothesis, so dopamine is one of the main neurotransmitters in the brain. So there are four main tracks in the brain that use dopamine. So the hypothesis is that in the mesolimbic pathway, which controls our emotion, our reward system, our memory. So there's hyperdopaminergic state in this area, which give rise to what we call positive symptoms. So you start to have all these hallucinations, delusions, but also you have hypo. So in limbic system, you have hyperdopaminergic, increase in dopamine activity, but in the frontal lobe, there's hypodopaminergic activity, which give rise to alogia, reduction of speech, affective flattening. The patient becomes blunted, evolution, they have no motivation, and so on. So this is the two main symptoms of schizophrenia: the positive symptoms and the negative symptoms. It's related to the brain pathology, the dopamine activity in the brain. So hyperdopaminergic in the limbic system and hypodopaminergic system. Hypodopaminergic activity in the frontal lobe. There's also environmental factors. Stressful life event normally will increase before the onset of schizophrenia. Adverse living condition, that's called the lower social class theory. It's affecting more of the poor people. There's downward drift and downward shift, and family interaction pattern, especially among those who have high emotional expression and so on. So these are some of the etiology causes that cause schizophrenia. So let's move to what are the clinical features. So I mentioned earlier, can be divided into positive symptoms and negative symptoms. So positive symptoms that to be excess or distorted of the normal functions. So examples, the hallucinations, delusions, disorganized behavior, disorganized speech. So these are all positive symptoms. Negative symptoms are diminution of or loss of normal function. So let's look at positive symptoms. So positive symptoms is hallucinations, which is again psychotic important symptoms of psychosis. So disturbance of perception I mentioned earlier. So patients start hearing things, seeing things, smelling things that others can't. So delusion is a thought content disorder. They start to have all the abnormal beliefs, fixed false belief normally. Can be bizarre, can be something that's possible. Sometimes can be something that is so bizarre, something that's absurd. Patient will also have disorganized speech. So they have like looseness of association, we call it. So when patient try to speak about their idea, is disorganized. We can't understand what the patient is trying to say. So this definitely affect the patient's communication. And they also have disorganized behavior or catatonic behavior. So it can suddenly become aggressive. They lack their personal hygiene. They start wandering around on the streets. Don't wear proper attire and so on. So these are some of the examples of disorganized behavior. So all these are under positive symptoms. So negative symptoms, we have what we call affective flattening. So there's face becomes immobile, unresponsive, very poor eye contact, significantly reduced in body language. They feel like a robot. Evolution or apathy, lack of energy, or interest in performing routine activities like grooming, bathing, personal hygiene. Alogia, so there's absence or poverty of speech and content of speech. So these are another symptoms or negative symptoms. And anhedonia, inability to express or feel pleasure. So they cannot feel happy because of this. It's again related to the dopamine system. So we need dopamine as in our reward pathway. So there's reduction in the dopamine in the frontal lobe, giving rise to this anhedonia. So these are the other symptoms of schizophrenia. So we have the positive symptoms, the delusions, hallucinations, disorganized speech. Negative symptoms I mentioned, but of course the patient also have mood symptoms. If you start hearing voices, you believe the whole world is against you, then you obviously feel depressed. You feel hopeless, and if you feel that the people are trying to harm you, you react to that belief and becomes aggressive and hostile towards the other people. So these are the common symptoms. And there's a high risk of suicide. So actually, among the mental illness, the highest risk for suicide is actually schizophrenia. We always thought depression have higher risk, of course, true. 25 times higher risk of suicide compared to the general population. But patients with schizophrenia will have 37 times higher risk of suicide because of the psychosis and because of the depression. They have both symptoms. So this increase the risk. And patients with schizophrenia have shorter life expectancy than the normal population. On average, they die 10 to 15 years younger than the normal population. So this is high mortality kind of illness due to suicide and also due to other disease, including cardiovascular disease. They also have cognitive deficit in terms of executive functioning, attention, memory. So these are and there's high comorbidity with substance use as well. So all these will definitely interfere with patients' function, relationship, social relationship, work relationship, and their own self-care. So this is a very serious chronic illness. So how to diagnose? This is more academic. So based on the Diagnostic Statistical Manual, DSM-5 criteria. So this is how psychiatrists diagnose schizophrenia. So criteria A, you must have 2 or more of this in this 1 month period, either delusions, hallucinations, disorganized speech, disorganized behavior, or negative symptoms. So you have any 2 of these for at least 1 month, then you have fulfilled the main criteria A, and must have occupational or social dysfunction at a significant portion of the time. And the duration must be persist at least for 6 months, including 1 month of active symptoms of psychosis. So sometimes we have what we call a prodromal symptoms. They started way before, 1 year before sometimes. And it's also a very chronic kind of thing. So you have to rule out other medical condition as well, brain tumor, infection, use, and so on. So I mentioned earlier, the mortality rates are very high. So on average, they die 10 to 15 years earlier than general population, mainly because of the suicide, 37 times higher than general population. But also they have higher risk of cardiovascular disease, diabetes, obesity, and substance abuse. So patients with schizophrenia also have higher rate of diabetes compared to general population, probably genetically linked. Also higher rate of obesity, probably because of the medication that they're taking, it causes sedation, increase the weight, increase their appetite. They are not active. They don't take care of themselves very well. Lack of poor hygiene, personal hygiene, and so on. They tend to smoke a lot. More than 50% of the male schizophrenia smoke, and about 30% of them abuse drugs as well, especially cannabis. So this is increased again. In all this will increase the mortality rate. So impact have a significant impact to the patient. Definitely significant impact to the patient in terms of functioning, social function, psychological, occupational function. Also high burden to the caregivers. Like I said, this is very stigmatizing condition. So a lot of families feel ashamed if they have patients who have schizophrenia. So there's caregiver burden, embarrassment, and there's probably lack of social support and stigma associated with schizophrenia. There's also high economic burden on health expenditure. There's one publication, and it costs the cost of schizophrenia is estimated to be around 500 million to Malaysia. This is Malaysian data, 500 million a year, especially in terms of loss of function and also because of the cost of treatment. So treatment-wise, you can use what called biopsychosocial. So the most important treatment is to use medication. Like I said, we have very effective treatment. Antipsychotic are the mainstay of treatment. Of course, you also use psychosocial treatment, which are also very important. So it's not just medication alone, but medication is the most important one. And we also have to use psychosocial treatment. So this is the history of antipsychotic. So of course, I think you all, the older generation will know haloperidol, copramazine, still widely used, but this is what they call the first generation antipsychotic. associated with a lot of side effects. Now we have second generation antipsychotics, clozapine, amisulpira, risperidone, quetiapine, olanzapine. These are the second generation antipsychotic, which is much better than the first generation antipsychotic, but they do have their own side effects as well. So the newer group of antipsychotic we call the dopamine partial agonists, example, aripiprazole, brexpiprazole, cariprazine. So this is considered as the third generation antipsychotic, which is much safer, also very effective medication. But the problem is because they are new, they are relatively more expensive than the first and second generation antipsychotic. However, they are very effective to control the psychotic symptoms, the negative symptoms as well. And there's also depot preparation for a patient who have poor insight, they don't want to take oral medication. So we can give injection. So we can give what we call paliperidone monthly injection. We even have 3 monthly injection, paliperidone, or even 6 monthly. Give the injection once in 6 months. But the 6 monthly is not available in Malaysia yet. Now we have up to 3 monthly. We also have aripiprazole depot. We can use once a month. Yeah. So I mentioned earlier the first generation, second generation, third generation, and of course the third generation is with the least side effects compared to the first 2 generation. In terms of efficacy, all first generation, second generation are relatively similar efficacy, but the difference is only in terms of side effect profile. So the third generation have one among the safest compared to the rest. So treatment challenge is the compliance. Patient with schizophrenia, main thing, they have poor insight. If you have psychosis, namely, you have poor insight. You are not aware that you're having that symptoms, the abnormal symptoms. Because to you, it's all real. The voices are real, what you're seeing are real, your beliefs are real. So then if you think that's real, why do you need to take treatment? Because you are not sick, you know? So you have poor insight because you are not aware of your illness. So one example, you watch the movie Beautiful Mind. So that's a very good portrayal of schizophrenia. If you have the chance, you can movie Beautiful Mind. So
the Australian guy,
Russell Crowe. So it's based on a real story. The
can
mathematics.
I ask you?
Yeah.
Your treatment is a dopamine agonist.
Yes. Dopamine antagonist, not agonist, antagonist.
And you go back to the previous slide, please.
Sorry, it was cut off. Sorry. Dopamine
Okay, the
antagonist.
previous slide. Can you show us the previous slide, please? Okay, so dopamine antagonist here. The third generation is dopamine partial agonist.
Okay. Yeah, good observation. Okay.
Yes.
So the theory is the dopamine hypothesis, that's hyperdopaminergic at the limbic system. So you want to block that. So you use dopamine antagonist. But if you block dopamine at the frontal lobe, you already have low activity.
Yeah, that's right.
So that you become worse in the negative symptoms.
Yes.
So that's why the first generation, they improve the positive symptoms, but the negative symptoms become worse. You know. So you give haloperidol.
So sometimes they look like dazed. They can't see people. They're like stoned.
Yes.
Like
so that's why the old generation, you use haloperidol. From far, you know patients on antipsychotic because of the side effects. So that one we don't want.
Okay.
So that's why they have the second generation, it's called serotonin dopamine antagonist, improve on that function. But the best is the third generation, which is the dopamine partial agonist. So this is like a dopamine stabilizer. So at high activity, it blocks the dopamine. So at the limbic system, it reduces the dopaminergic activity. But in the frontal lobe, there's reduction in the activity. It stimulates the activity.
I see.
So it's like a smart molecule, you know.
So when it's both agonist and antagonist depending on the level of dopamine.
Exactly.
Okay.
So the activity is too high, it lowers down. So the activity is too low, it stimulates the activity.
I see.
It's like a controller, you know. You can increase the the level.
So now you can believe that I am paying attention.
Yes, definitely you're paying attention. You are the moderator. You are very important to pay attention. Okay. So compliance, I mentioned earlier, because patients have poor insight, so they don't want to take medication sometimes. That's why you need to give sometimes depot injection, monthly or even 3-monthly injection. And because they don't take medication, increase the risk of relapse and hospitalization. If they continue taking the medication, they probably will achieve what we call remission. There's no cure, but they at least they can recover as long as they continue taking the medication. But if they stop, then the risk of relapse is very, very high. The moment they stop, about almost 90% of them will relapse, and the condition will deteriorate, because this hyperdopaminergic state will kill the brain cell. Just like in diabetes, your hyperglycemic state will cause a lot of cell damage. The hyperdopaminergic state also will kill your brain cell. So if you don't treat, that's why it becomes chronic and they never return back to function. So compliance to treatment is very, very important.
Would you say the
So
treatment
non-pharmacological
is lifelong?
therapy includes psychosocial rehabilitation, psychoeducation, social skill training, how to improve communication, and work programs, supported employment, and so on. So there's a lot of psychosocial rehabilitation that needs to be done for this type of patient. I think for summary for this first case, this is the first half of the talk. So schizophrenia is a severe mental illness. So early treatment is important because we have effective treatment, but make sure they stay on the treatment to maintain well. If they keep on skipping medication, keep on having relapse, then the illness, the prognosis become poor. So compliance to treatment will improve the quality of life, everyday function of schizophrenia. So they can go back to normal life, provided they continue on treatment. And treatment is normally lifelong. The moment they stop, the disease will recur.
So
Okay?
how did your patient do? How did your patient do, this gentleman?
Okay. We diagnosed schizophrenia. So we give antipsychotic oral initially. So after a few months, he recover well. But I've mentioned earlier, he have poor insight. So after about 4 months in treatment, he stopped taking medication because he said it's okay. Wife also did not monitor properly. So he had another relapse. So need an admission. So second admission, also the same thing. He fight with the boss, try to punch him and so on. So this time we give injection, depot injection. So with depot injection now, every month he come, he's okay. So he's still working. No more psychotic symptoms, and so far he's still functioning. But we continue giving depot, and we have what we call a community psychiatry team, where our staff will go and visit the patient at home, but it's not for all. It's within 15 kilometers radius from PPM only. So those patients, sometimes we go and visit them, make sure they are okay. If they don't come for treatment, we give the depot injection at home. So, so this gentleman improved.
I am always my memory of medical school, right? A lot of it come from psychiatric patients.
Okay.
I remember one patient, he's 19 years old. Though we think that a lot of people believe in this black magic, therapy and all, but this 19-year-old was actually brought to the hospital by the mom. Said that the son can hear voices, talking to himself, and obviously he looks like he was like in layman term crazy. And it was my first week in psychiatry, and I was like shocked. Okay, but the shocking part was after 2 weeks of treatment, he came back. He's absolutely normal.
Exactly. So that's what I'm trying to tell you. That's what I'm trying to emphasize here.
I was so amazed. Yes, well, another guy I met who was 24 years old, he killed his father. He works in the construction site, and then he keep on hearing that the father is going to kill him. So one day, very pleasant guy. Okay, so very pleasant guy. When I spoke to him in the ward, but he took the like a piece of metal piece and then he went home and stabbed the father many times to death. Very sad.
Yeah, that's sometimes can be very tragic. So that's why treatment, early detection, and treatment is very important because they can go back to normal.
Yeah,
But
can go back to. I was so shocked, you know. I was
Yes.
like, wow. At that point of time, and that was like 30 years ago. Can
Yes.
you imagine the amount, the medicine now? Yeah.
Yeah.
Okay, let's go on.
Okay, so we go to the second case.
Yeah.
So a second case is a 21-year-old male student, single. So this time brought to the emergency department by parents and police. So this one is more acute. Parents noted changes in behavior for 2 weeks. Patient was easily irritable, very paranoid. Patient stopped interacting with them, isolating himself in the room, doesn't want to eat the food prepared by the family, and stopped going to college for 2 weeks, doesn't sleep at all, and started to talk to himself, shouting in the room for past 1 week. And one day prior to the admission is even having threatening behavior, threatening the parents with a knife, you know. So because of that, the parents are very scared and called the police. So patient said to the police that the parents was planning to kill him. So before they kill him, I better kill them.
Yeah,
first,
yeah. Sound like my patient. Sound like the patient I saw. Yes.
Okay. The patient had no previous psychiatric or medical illness. So upon further questioning history, he's been abusing shabu, methamphetamine, for 2 months. So it was introduced by his friends from college. He said to relieve stress. So you want to increase energy, you want to study more, don't need to sleep, then you take shabu. Yeah? You feel good, you feel happy. And so in the emergency room, so because he's very aggressive, so you give him diazepam, haloperidol, because you want to hit the staff as well. So subsequently, he was admitted to psychiatric ward for further management. So this is different than schizophrenia. So this is what we call drug-induced psychosis. So one of the most common causes of psychosis now is what we call the stimulant, the amphetamine type stimulant. So what we call ATS in general. So it's a group of drugs, including amphetamine, methamphetamine, and MDMA. So long, I cannot. So just say MDMA lah, or ecstasy. Yeah. So MDMA is actually ecstasy. So there's also other category of drugs, including our phenytoin, ephedrine, pseudoephedrine, our medication for URTR. Yeah.
Why?
So this is the precursor to if you want to produce methamphetamine, you need all this ephedrine and pseudoephedrine.
Oh, I see.
That's the bahan mentah, you know, the ingredient.
The basic,
the basic ingredient of methamphetamine is ephedrine, pseudoephedrine. Of course, you can Google the formula. You can do it at home. But not advisable because
it'll be like Breaking Bad.
because the police might raid your house. Okay, so these stimulants actually can have some medical use. Yeah, like Ritalin. It can be used for ADHD or in narcolepsy. That means sleep disorder. Patient will be sleeping all the time. So you need to use stimulants, or chronic fatigue syndrome. Sometimes you use stimulant. But unfortunately, a lot of these drugs are abused, illegally used for recreational purpose in clubs, discos, and leading to a lot of negative consequences, especially psychiatric complications. So these stimulants come in different forms, different names. So they are very versatile. You can smoke them, you can sniff them, you can inhale, you can inject. So you can use whatever methods that you like. So methamphetamine found in the streets in form of powder, crystal, or even pills. So it's white, odorless, bitter tasting, and you can easily dissolve. So you can mix in the water, in alcohol, or you can smoke it, you can chase it. So multiple methods of administration. So the most common, the one in Malaysia is called ice or shabu or crystal. It's one of the most purified form of methamphetamine. So they wash it in solvent to remove the impurities. It's as high as 80% meth, but it have very long-lasting physical impact. So I've mentioned it. You can use various ways. So this is how it looks like. Crystallized is a form. So it also comes in pills. In Thai called yaba, crazy medicine, because they can become crazy. So again, you can ingest orally, you can dissolve, crush, inhale, snort. So you can use various methods of consuming it. And ecstasy also normally comes in powder or pills. So I mentioned earlier, you can easily produce. You don't need to plant, not like morphine or heroin. You need the poppy seed and so on. This one, no need.
What is synthetic?
Synthetic, yes, it's synthetic. So the ingredients are easily available. You buy some Actifed, pseudoephedrine from the pharmacy. You have some acid, ammonia. Google for the formula, and then you can do it at home. It's relatively inexpensive. No need to have degree in chemistry. No need specialized skill. That's why it's very, very rampant. Mega lab is available in Malaysia. A lot of these clandestine lab available in Malaysia. So how it affect? So basically, when you smoke the methamphetamine, it's go to your brain very fast, and it lasts between 6 to 8 hours. So methamphetamine will enter the brain cell and release dopamine. Again, the key neurotransmitters tonight is dopamine. So dopamine is always involved in any addiction.
Hello?
One of the
sorry, you're breaking up.
For us to be happy, have increased energy, to increase our, dopamine is very important neurotransmitters in our reward pathway. For us to be happy, increase energy, euphoria, we need dopamine. So that's why all these stimulants, they release lead to release of dopamine from the nerve cell. Okay.
Sorry, can I ask you, you know the dopamine that we give as an inotrope to bring up the blood pressure?
It doesn't cross the blood-brain barrier.
Oh, it doesn't cross the blood. Okay, if not, I can use that.
Okay. Otherwise, all the patients are very happy.
Okay. Oh, it doesn't cross the blood. Right. Okay.
So dopamine is very important for our movement. If you have impairment in dopamine, we have what we call extrapyramidal side effect, extrapyramidal symptoms. We have Parkinson's disease because of lack of dopamine. You have bradykinesia, tremor. You have a movement disorder. So you need dopamine. You need dopamine to improve your mood, and also very important for reward pathway in the ventral tegmental area. To feel happy, to feel good, elated, you need high dopamine. And because of that, all the drugs of addiction always will impact the dopamine pathway. So this is
it's breaking up. Can you hear me?
Oh,
sorry, you're breaking up. Okay, we try.
Yeah, I can hear you.
Okay, now.
Is it breaking up? Okay. So the methamphetamine will shoot up the dopamine level. Just like cocaine. Cocaine is another stimulant, but this is not naturally occurring stimulant. It's a plant, but methamphetamine is the synthetic.
I see. Okay.
Okay. So what is the problem with methamphetamine? Problem is it doesn't produce dopamine in the brain. It only facilitate the release of dopamine. So our methamphetamine is just like our credit card. So it does not produce money. it allows you to use in advance the dopamine. So of
Okay.
course, like when you use credit card, you buy everything, and then at the end of the month you bankrupt, because you no
Okay.
money to pay. So
Good
similarly, like
analogy.
this, yeah. So
Okay.
you use methamphetamine, you use all the happy dopamine, and then of course, then that one day period, you'll feel ecstasy, elated because your dopamine is very high, but you have bankrupted the system. So this can lead to crash. So patient can become depressed, and opposite of the impact. Instead of happy, you feel depressed. Instead of energetic, you feel down. So that mean. So in order for you to sustain that feeling, you keep on taking the methamphetamine. So this causes dependence. Just like you use your credit card too much, and then you have no money to pay.
Then you use some more. You're breaking up.
Okay. Sorry, I'm not sure what happened with my.
I don't know whether it's mine or yours. Okay.
Okay. So there's a lot of negative consequence for drug abuse to the family, creating chaos in the community, increase the crime rate. There's a lot of economic negative consequence. So there's also withdrawal symptoms. So if you after you have depleted the dopamine system in your brain, you develop depression, you become easily agitated, you have sleep disturbance, fatigue, irritability, hyperphagia, intense craving. So these are the after effect of using the drugs. Long term, it causes depletion of the dopamine. It can cause cognitive impairment, behavioral deficit, memory problem, almost like Alzheimer's disease. It also promotes aging. So you want to look older than you can, because it promotes aging, progeria, because it loss of a lot of weight, especially the facial muscle. There's a
There's
severe
also a
dental
lot of
decay,
skin
weight
lesions,
loss. So
right? Sometimes you have
yes,
skin
definitely,
lesions, right?
exactly. You're correct. The next slide I will show that.
Okay.
So there's ischemia, cardiovascular, especially if you have used IV, can induce stroke, respiratory problem, infectious disease, STD, HIV, skin lesion, mainly because of the acid that you use to produce to process it. They use a lot of acid, strong acid, and ammonia. I think. So because of that, they develop like allergic reactions to this chemical. So they have all these skin lesions. They have abscess. They feel something crawling under their skin, and hepatotoxicity as well. They develop giant ulcers because when you take methamphetamine, you don't feel hungry, you don't eat. So they
Oh my God.
yeah, and the erosion from the strong acid. So
I see.
chronic use. So if you see a young man, relatively young man with this teeth problem, always suspect stimulant abuse. They have that peculiar dental, poor dental hygiene and this dental decay. This is always one of the signs. And of course, psychosis. Yeah? So stimulant users are high risk for psychosis. So especially if they have underlying mental illness, the risk of psychosis is even much higher. Symptoms almost like schizophrenia symptoms, irritability, aggression, but they become more aggressive normally, even more aggressive than patients with schizophrenia. They're threatening, like you said, they even stab people and so on. So this can be dangerous. So we did a study a few years back on this methamphetamine dependence patient. So we recruited 292 patients. Because Sabah have a lot of methamphetamine dependence at that time. And we found out that half of them have psychosis. And even so, half of them have psychosis. And even during interview, 13% are actively psychotic at that time. Yeah? So it's very, very high. So this can be a very dangerous complication of methamphetamine. Yeah?
Could
All
it
right.
be possible that they have psychotic syndrome symptom before they started met?
Yes, it's also if they have schizophrenia, for example, or bipolar, and if they use methamphetamine, it potentiates the psychosis even more. The risk is even probably 8 times more than those who have no mental illness. So there's other risk factor, like if you use it higher in amount, you use it chronically, you have mental illness, especially like schizophrenia, depression, bipolar, the risk of psychosis is even much more. But even if you don't have mental illness, if you use stimulant, the risk is also very high, as high as 47% just now. So the treatment is just giving antipsychotic, but not like schizophrenia. You don't give lifelong. So the
Wi-Fi is terrible. Okay. Hello? Can you hear me? Hatim? Hatim?
Sorry, it's breaking. Sorry, breaking up.
Okay. So basically, sorry about it. So, for example, right, are people genetically more inclined to addiction?
Okay, there have studies to show that your family history of addiction increase the risk. It's either because of genetic or environmental factors. You see your father abuse drugs, so you follow. It's like learning theory, you know. So it's either genetic or environmental factors, but it's not just genetic. Genetic doesn't really very strong. It's more of environment, peer pressure, availability of the drugs, psychosocial stressor. So it's again multifactorial.
Okay.
Yeah.
Because I feel like I have what you call that, an addictive streak. Because when I went for, let's say, I went for a major surgery once, and I was put on Petidine for pain relief. I didn't realize it, but one day I was driving, and then I was almost hit by a lorry which swerved, you know. And then the first thought that came to my mind was, wow, if I get admitted, I can get Petidine. I was shocked. I was shocked, you know. I was completely shocked.
Okay, that is not addictive streak, but because all this give to euphoria, you know, all this medication. So of course, our brain will want something that is nice. This is part of the mechanism, animal instinct. For example, when you eat something nice, your dopamine level will go up so that you remember that environment, that event. So let's say you have a nice roti canai. And then you remember that shop, you know, that taste. So next time you know how to go there. So part of survival. But that doesn't mean you're addicted to roti canai. That's
craving, craving.
Craving, yeah.
Maybe the word is craving.
So that makes some substances are very difficult to stop.
Okay. Dr. Susie from Doqueti asked, what are the early signs and symptoms of psychosis?
One of them is
and how to differentiate them from other mental health condition? Okay, that's a good question, because we know that there is also, how you call it, manic depression. disorder.
Okay.
So how do we really differentiate these two?
Okay. Psychosis is very obvious. Everybody will know psychosis. Hallucinations is symptoms of psychosis. Delusions is symptoms of psychosis. It's very obvious. If you talk to someone who has psychotic, you know it. So that's I think positive symptoms not difficult to detect. But the one that you mentioned just now is more related to mood disorder, which is like bipolar. Bipolar is a mood symptoms. So the main presentation is irritability or manic. So that is emotion. So psychiatric illness can be divided into few major categories. One is psychosis, which I covered today, including schizophrenia, delusional disorder, drug-induced psychosis. These are all psychotic disorder. But it can also be divided into mood disorder, which is depression is one. So the predominant symptoms is mood emotion. You feel low, you feel down, you can't enjoy yourself. So that's depression. Or another condition is called bipolar. The patient present with manic. They have elated mood. They feel happy. There's no reason to feel happy. Persistently happy, irritability. But for mood disorder, if it gets serious, they can become psychotic as well. So this is sometimes make the diagnosis a bit difficult. But normally in the beginning, they don't have psychotic symptoms.
Normally beginning they don't have psychotic symptoms.
Yes, like depression, they don't. Only when it's become severe, they become psychotic. But they have psychotic symptoms during the severe part. But mood disorder in general, mild to moderate, but they don't have psychosis. The severe ones might have psychosis. Another major illness is anxiety disorder. So this includes panic disorder, obsessive compulsive disorder, social anxiety disorder, post-traumatic stress disorder. So it's another set of symptoms altogether. And addiction disorder is another set of symptoms. So there's a lot of different diagnoses that we have to deal
means we will have more webinars from you.
Yeah, can.
Okay. Dr. John asked, what are the available treatment option for individual experiencing psychosis? I think you have covered that quite well because he asked very early in the word. And how do you, okay, we have already covered that, Dr. John, because he asked that before he asked that at 9:14.
Oh, okay.
So we more or less cover it. Other than dopamine, what other, because how about serotonin? Is it involved in psychosis in any way? Only mood?
Okay, all the receptors in the brain are interlinked, interconnected. So it depends because dopamine is more easy because it's only 5 subtypes and only about 4 or 5 areas of pathway that use dopamine. Serotonin is more complicated. There's hundreds of different subtypes of dopamine receptor. And it is interlinked. It depends whether it's postsynaptic or presynaptic receptor. So it's a complex relationship. But you are right. Dopamine, serotonin, noradrenaline are very important for mood. But psychosis normally involve dopamine. But certain drugs that stimulate serotonin can also impact the dopamine. For example, if you block the 5-HT2C, the serotonin 5-HT2C is a serotonin 2C, then it induces release of dopamine. So there's a lot of interconnections and that affect different areas of the brain. So it's not that straightforward.
Okay, there is a question from Dr. Chu from Dokweti. Does psychosis or schizophrenia have any association with any personality disorder?
Okay, okay. Personality disorder is a different set of illness. Okay, so schizophrenia, bipolar, depression, all is what we call axis 1 diagnosis, the main major psychiatric condition. Personality disorders are under what we call axis 2. Personality are something that we are developed from young. Yeah? So our traits, all of us will have certain traits. So when we have abnormal traits, we label it as personality disorder. So there's a lot of different types of personality disorder. You have like antisocial personality disorder. So these are more common among the criminals. They have disregard of other people's feelings, or so they just simply take other people's items, for example, or they don't care about how you feel. So these are antisocial. They are normally criminals. Sometimes the road bullies are antisocial as well. They don't care. They just cut you. They hit you. So these are antisocial. Some of them are what's called borderline personality disorder. That's chronic emptiness. They also have like schizotypal, schizoid personality disorder. Of course, certain personality disorders have higher risk of developing schizophrenia, especially the what we call schizoid and schizotypal. But that's another set of lecture that to make it.
Okay, we will do that. So I'm very interested in this personality disorder.
Because you have this.
Is it very difficult to treat?
Okay, personality disorder, very difficult to treat because you are already deeply ingrained with your personality. For example, if you are a sloppy kind of person, or you like to you are not something, don't really care about the hygiene, for example, from the beginning, from very young, you are used to that. How to change it already, So personality is something that's already stable. So it's very difficult to change your personality. So it requires a lot of what we call psychotherapy and other therapy. Unlike schizophrenia, it's not part of your personality. It's an illness. But personality is your traits. From young, it becomes stabilized. And we call it disorder because it's a maladaptive traits.
Okay, we will definitely cover that. Dr. Stephen asked, does anandamide receptors play any role? Anandamide.
Sorry, what is?
Okay, you look at the chat. There's a under bottom.
I can't find my chat. Sorry.
At the bottom, next to share screen on the left-hand side, next to share screen.
Left-hand side only have participants, stop video, mute. I don't know why my chat.
Okay, so
sorry. Okay, sorry. Yeah, I found it.
Okay. Do you see the question Dr. Stephen asked us?
And then the mean receptor. I'm sorry, I'm not sure what is this.
I also never.
I'm not very familiar with this receptor. Sorry, Dr. Stephen. I need to read up. Sorry. And then the mean.
Yeah, and the might. Okay, so okay, there are no more questions. Okay, Dr. Karamjit Kaur said, I once saw a catatonic schizophrenia. Is the symptom similar to schizophrenia? Yes,
catatonia is one of the subtype of schizophrenia, one of the severe ones. They are become immobile, unresponsive, and this type of patient normally require what we call electroconvulsive therapy. We give electric shock to this patient, and works wonderful. So this is more severe form of schizophrenia, but this one rarely seen now. With only probably in huge hospital, you can see catatonic schizophrenia now. Yeah. So this is a more severe form of schizophrenia.
Have you been to America where you see a lot of psychotic patients on the road?
Yes, there are psychiatrists in America are more difficult because there you can carry firearms, So you are psychotic, they bring guns, that's it,
Yeah, in San Francisco, right?
Yeah.
A lot of the homeless are psychotic,
Yeah, true.
Many.
Yes, correct.
Yeah.
So it's worse than here actually, because their system is not as good as Malaysia. Malaysia is definitely better in terms of
Wow, I
all
tell
the
you,
time,
it's
yeah.
quite scary.
Yes, correct,
Okay.
correct.
So with this, we end our session. I'll stop recording, and thank you very much.